committee and CIPLA for organizing this session. Today I will be talking about CGM in routine nephrology care. Now, I currently try to take you all through the limitations of HbA1c, review the CGM technology, and how to integrate the CGM data into the CKD and dialysis management, discuss the real world and trial data, and few case-based applications. Now, we all know that diabetes is highly prevalent in CKD individuals. Around 30 to 40% of CKD patients have diabetes. And glycemic control is very crucial to prevent CKD progression and to better the CV outcomes. But there are certain challenges in that. There is altered insulin clearance. Most of the medications need some dose adjustments, and on top of that, dialysis has significant effects on that. Now, why HbA1c falls short in CKD? HbA1c is the measure which everyone uses to use and to adequately control blood sugars. But HbA1c has certain pitfalls while it is being used in CKD, because HbA1c can be falsely low because of transfusions, ESA therapy, reduced RBC lifespan, and also the significant anemia. At the same time, HbA1c can falsely rise due to uremia, carbomoylated HbA1c, like that. The other markers such as glycated albumin or fructosamine are also not very good while they are being used in CKD. And another major issue with HbA1c is that it cannot detect the glycemic variability or nocturnal hypoglycemia, which is a major issue in individuals with CKD. Now, SMBG is another thing that we commonly practice, but the issue is that SMBG has only 4 to 8 per day measurements, whereas CGM has around 288 per day measurements if used at 5 minutes intervals. Trend info is very limited in an SMBG, whereas CGM has real-time trend arrows and alerts. Hypoglycemia detection, SMBG might miss, whereas CGM can detect nocturnal and asymptomatic hypoglycemias. And variability assessment is poor in SMBG, whereas it is excellent while using a CGM. Now let's have a small discussion about the use of CGM.
Yes. So just now, Dr. Sonu shared the limitations of HbA1c. So one important point is the uremia. Because of the carbamylation, HbA1c can be falsely high. And someone seeing the HbA1c, everyone tends to hike the insulin dose or OHs, and actually the sugars are actually very low. So my practice is I don't use HbA1c in advanced CKD like stage 4 and 5, even stage 3B. So, but there is no strict guidelines or anything recommendations like this. So because the evidence and studies and all these areas it's not that great, that volume is not there. That's why there is no particular recommendation that don't use CGM, don't use HbA1c after a particular GFR decline and all. So it will be always worth to know how our nephrology colleagues and seniors do practice, how they monitor the blood sugars. So whether they use an HbA1c or is just based on the glucometer values or CGM. So I think we can just start. I think I should start from Dr. Sadish sir. Sadish sir?
Yes, tell me. Yeah. About CGM device.
So do you use HbA1c in advanced CKD?
Yeah, I'm using HbA1c because nothing else is there in advance. But then I'm also careful. I use the fasting and postprandial, and I ask them to maintain records of SMPG. So these things we are doing. Once in a while, patients who can do it, then I ask them to get the CGM also. So I'm using all of these. You said problem?
Like as the advanced CKD patients, say CKD stage 5, the sugars are always very low. They go to an ophthalmologist to get a cataract surgery done. So they do an HbA1c. It comes like 10. But always the patient's blood sugars are very normal, very low. In fact, always in hypos. But the HbA1c is very high because of the carbamylation. So why can't we just take a policy like don't look at the HbA1c and confuse everyone in advanced CKD? So, but the literature and all is not very supportive. So, Mohan Rajabukar sir, your take on this?
Well, I do ask patients to do fasting 2 hours postprandial and pre-dinner 2 to 3 times a week, and bring it as a record when they come for follow-up. A1C, as you rightly say, is a poor marker in advanced CKD, but I'm not so sure whether carbamylation itself increases, whereas advanced glycation end products do increase the A1C. As their age advances, as your CKD advances, the advanced glycation end products, glycation of hemoglobin is also like an A1C is advanced glycation product, not so much as non-reversible, but reversible glycation end product. So it is difficult to manage, but if you are measuring A1C, I don't worry about till it goes beyond 8. I think when it goes beyond 8, I think you get more hyperglycemias. And I use CGM only if my patient have got a insensitivity or they do not recognize getting hypoglycemic. And such an episode, if it is documented, then I use CGM and not otherwise. I agree that A1C is not a very great marker for advanced CKD. But most of the stable patients, if they have come with a diabetic nephropathy to you, much more glycemic control is not really going to do anything to the kidney and protect any kidney there. But when you go from to dialysis, we often keep glucose in our dialysis rate, about 200 milligrams per deciliter. And I don't do a glucose-free dialysis so that they don't get hypoglycemia, because we are really worried about hypoglycemia, particularly asymptomatic, rather than hyper. So that's my take on it. It wasn't available in early part of my practice at all.
Yeah.
So, and luckily we have CGM now. So if we have a confusion, we can just put a CGM and see how the continuous glucose is, but only constraint is cost. Over to you, Sonu. So let's have the next poll. So can you host the poll? Launch the poll. So which CGM systems are you most familiar with? So only if very few percentage of attendees are using CGM, so they can answer which CGM systems you are familiar with. Because Sonu will be just comparing the different CGM systems available in the market. Yes, I think you can show the results. So Freestyle Libre, 27% is using Freestyle Libre, and Medtronic is being used by 15%, and the majority are not using any CGM. So over to you, Dr. Sonu, just to orient us about the different systems available in the market for which we can use.
Most of the time, the Indian CGM systems uses Abbott Freestyle Libre and very rarely Medtronic Guardian, as the poll has correctly shown. Dexcom is not very widely available in India. The major difference between Freestyle 2 and other things is that there is not much calibration is needed. And the other thing is that the initial Freestyle Libre had only a memory storage of only up to 8 hours. So that they needed to be scanned at least once in 8 hours to not lose the data. But the Freestyle Libre 3, the latest one, has storage of 14 days, and the warm-up time is much less in Dexcom. That is, if you are applying CGM for the first time, the readings will start coming only after 60 minutes in Freestyle Libre, and Medtronic takes 120 minutes as warm-up time. Whereas in Dexcom, the warm-up time is only 30 minutes. The range of glucose is almost similar in all these devices, and the duration is maximum for freestyle liberates and Carson's it is for 15 days, and the Dexcom has for 10 days. But there are few CGMs which are available which can be worn up to 90 days. Now, coming to the
and just so Dr. Sonu has just shared the different CGM types, and as of now, by default, if it is CGM, it is always about freestyle libre. Initially there was Pro, now 2, and now they are coming up with 3. So it will be always great if you can just know about the cost of all the CGM also, as these different types of CGM is being discussed. So Sonu, can you just share the cost, approximate cost, or I will share?
4,600 rupees per sensor is the cost for freestyle libre. Dexcom, I was not able to find out the cost. Guardian is almost similar.
Yeah, freestyle libre 2 is widely available in India. It is available online. We get some offers, and for one sensor which can monitor the glucose for the 14 days, we have to pay for around 5,000 rupees for the 14 days continuous monitoring. So it's very costly, but useful if you use it very judiciously. So over to you, Sonu, for the next poll.
Yeah, we are going to do the CGM metric.
So in CGM, you the glucose values. The glucose is being sensed not from the arterial blood or the venous blood. It is from the interstitial fluid. This glucose is being monitored or measured. So different values we'll get. So time in range, time below range, glucose variability, and all. So those who have used CGM, can you just share which value you find most useful? Nearly 30-35% people are using CGM. So which value you consider as most useful for your CKD patients? You can share the results. So time in range, yes, this is which is conventionally considered as the most important parameter, and all of the above. So everything is important. So Dr. Sonu will be enlightening us about the different crucial parameters like what is time in range, glucose variability, etc. Over to you, Dr. Sonu.
There are two, CGM can be used for two purposes mainly. One, for the patient to have control over his own blood sugars, and for the clinician to have an ambulatory glucose profile, which will be the continuous glucose metrics which is recorded over the 14 days. But for patients, they can use, like if they have the mobile sensor, current CGM devices can accurately relay the data into the mobile apps, and they can actually identify hypoglycemia and hyperglycemia by then their own. And also they can actually adjust their insulin doses based on that. But we commonly use CGM to find out whether there are any hypoglycemias or the glycemic variability. So for that, you need to have an ambulatory glucose profile. In that, the major metrics which are applicable are TIR, that is time in range, TAR, that is time above range, TBR, that is time below range, coefficient of variation, that is CV, standard deviation, that is SD, GMI, which is the glucose management indicator. This I will explain in detail in the coming slides, but there are few other things which needs to be known. If you are keeping CGM for 14 days, minimum recommended duration is 14 days. Percentage of time the CGM is active in all those days is also important. It is 70% of the days for minimum 14 days. Now, all these things has cutoffs. Mainly when we are considering time in range, the sugars are between 70 to 180. And level 1 hypos are between 54 to 69. And level 2 hypos are less than 54. And when time above range, that is level 1 hyperglycemia is from 180 to 250. And level 2 is more than 250. Now, if you are seeing the CGM traces, you have to review the stepwise trend arrows, find out the time in range. find out whether there are any hypoglycemia and postprandial sites. And on the dialysis days, you have to analyze the segment of the dialysis and also the segment of the non-dialysis. Now, the CGM trend arrows, if you see, there are various trend arrows which indicates how the blood sugars are, either the blood sugars are going up or the blood sugars are stable or the blood sugars are going down. The commonly used freestyle Libre has an upward arrow, a slight arrow, a straight arrow, and a low down arrow. Glucose is falling, glucose is rising quickly around 2 to 3 milligram per deciliter per minute, and in another 30 minutes, the sugar will be more than 60 milligram per deciliter. That is the indication of this arrow. This arrow is glucose is rising little bit slowly. Glucose is rising, changing very slowly if this arrow is happening. And the glucose is falling and glucose is falling quickly. These are the major arrows which are being displayed in a freestyle Libre. Now, if we come to the time in range, I have already told that the target blood sugars is somewhere between 70 to 180 milligram per deciliter. For a normal patient, what we aim is that his blood sugars should be in the target for more than 70% of the time. But in frail CKD individuals, if we try to achieve that stiff target, the chances that the patient can go for hypos. So there is recommendation to keep the time in target between 50 to 60% in frail and CKD patients. Time below range should be kept less than 4%, and coefficient of variation should be less than 36%. Now, another thing is that this CGM measures the blood sugars in the interstitial compartment. There is a lag time of 5 to 10 minutes between plasma glucose and the interstitial glucose. So there are chances that CGM will measure the blood sugars a little bit late. Now, variability and coefficient of variation. These are very important metrics while we are measuring while we are seeing the CGM chart. Because if there is low variability, that means that there is less hypoglycemia risk. And if there is high variability is higher hypoglycemia risk. And CKD, there is increased risk of high variability because of insulin clearance and dialysis effects. Now, previously we heard that HbA1c is not very good indicator in CKD. However, there is something called estimated HbA1c, which can be derived from the mean glucose values. And they use a population-based formula. This glucose measured management indicator and measured HbA1c may differ because especially in advanced CKD. And KDIGO 2020 states that if GMI can be used to assess glycemic control when HbA1c is under label. When you compare HbA1c and GMI, a large gap suggests inaccuracy of HbA1c. Now, hypoglycemia patterns in CKD, there are major two hypoglycemia patterns in CKD. One, there is the nocturnal hypoglycemia, and the second one is the intradialytic hypoglycemia. The most important advantage of CGM is that it can identify asymptomatic hypoglycemias because the majority of the CKD individuals can have hypoglycemia unawareness, and this undetected hypoglycemias can increase the cardiovascular risk in these individuals. So this can be prevented by using CGM to identify the asymptomatic episodes, and that can be used to guide the insulin adjustments. This is a sample ambulatory glucose profile report. This was worn for 14 days, and the percentage of time the sensor is active is 90, which is good, which is more than 70% which is required. The average glucose is 8.7, and the GMI, which is the estimated HbA1c, is 7.1%. And the blood sugars are very high for 12% of the time, high for 20% of the time, target range for 66% of the time. This is another report which is from an Abbott Libre, which shows the daily excursions of blood sugars. The average glucose is shown here, time in target is shown here, time below target is shown here, and time above target is shown here. Now, when you are having a CGM data with you, you identify the hypoglycemia trends, review the postprandial exertions, TAR and CV will be calculated for you, and segment of the dialysis and non-dialysis you carefully evaluate and adjust therapy and education based on that. Now, the interpretation zones, green is target, yellow you have to proceed with caution in that area, red intervention is needed if you see the graphs. Now, coming to the discussion on important CGM metrics.
Thank you, Dr. Sonu, for sharing how we have to interpret this CGM. And we have Dr. Prem. Are you here? Dr. Prem Narayanan.
Hello, good evening. Yeah, I'm here.
Yeah. I need to welcome. And Dr. Prem Narayanan is a consultant endocrinologist in Ahilya Diabetes Hospital, Palakkad, and he's also a renowned actor. So he do a lot of acting reels and educate the our people community with how we have to control the diabetes well. So I have a specific question for you here for defining the time in range and hypoglycemia.
Yes.
70 is considered as the threshold to define hypoglycemia. But
Correct.
our patients, our population is very different because we don't want a stringent glycemic control. All the, say, stage 4 and stage 5 CKD, all the damage because of the diabetes has already happened. If you want a stringent control, it should be for a newly diagnosed diabetes, because in the initial 5 years, we want to have a good metabolic memory so to get a long-term protective effect. It's all the damage has happened, and they're very prone for hypoglycemia. Is the 70 threshold default threshold in the CGM? I feel it is not apt for us. So at least anything below 100, I get panic. So I don't want any hypos. Anything below 100, they're all patients who have a long duration diabetes and they have hypoglycemia unawareness. So anything below 100, I do panic. So what is your take on it, on defining the hypoglycemic thresholds and how to interpret the CGM in this context?
Yes, definitely. As you were telling, all the damages has happened being CKD or patient on hemodialysis. So where we know that even without all these things, the patient is already prone for a hypoglycemia. And we need to avoid a hypoglycemia, and we know how detrimental hypoglycemia can be. So yes, the threshold is definitely we can uphold the threshold. The 70 can be, yes, it can put it up. In this scenario, the time in range also we do give a relaxation. So usually the time in range concept which Dr. Sonu was putting it up, yes, more than 70%, that is for, yes, a patient or a younger person with no comorbidities, or where we need a stringent control, yes, not even 70 or 80 or even 90 we can target. But in this kind of patients with a well-established comorbid illnesses, we definitely give a relaxation, and a time in range of even 50% or above is what the say that yes, that is also quite fine for patients with well-established chronic comorbid illnesses. As you were telling, the hypoglycemia, yes, all the sensors, we know the various, the mainly what we use is a freestyle Libre is the one that we use. And I have a few patients on Guardian because of the patients like who are on the advanced 780G Medtronic insulin pump. They have to use Guardian Medtronic sensor because that is the one that senses and gives all the information input to the Medtronic pump. So in that sort of subset only I use they have to use Guardian sensor, but otherwise all it is like the Libre, and the Libre 2 presently available. Yes, it costs around 5,400 rupees. So the cost factor is definitely an important, as Dr. Arun was discussing previously. What mostly we use is that to get a trend. So for example, we see many patients, even not only CKD, I see a few other patients even not having a CKD, but still they're all SMBG values. The self-monitored values are all quite good. But when we see the A1C, it is always in the 8%, 9% range. So in that patients also, it has been very helpful to see the time and range, and also the GMI, which Dr. Sonu was discussing, the glucose management indicator, so that we will be able to see and guide them whether because there are a very few subset of my patients in whom I have told that you never check your HbA1c at all. They do not have any CKD, they do not have any CLD, they do not have any cardiac but still their A1c is not a good marker for them. Yes, so A1c we know, yes, we use it left and right, but it has its own fallacies and limitations as this point of time. But the sensors are too costly that it cannot be widely used in our population. But more indigenous sensors, if it is going to come in the future, maybe in the 5 years down the lane, it is definitely going to get revolutionized, and more indigenous sensors will be helpful for us to use it widely, because that is the one, because the glycemic fluctuations differ individually. or even in the intra-person also, the changes can happen. The same person taking the same food yesterday, it might not be the same today, the glycemic fluctuation. So there can be variations. We see people telling that, doctor, I'm after taking rice, I'm not getting spike in glucose, but after taking the millets, the so-called millets, I'm getting the spike of blood glucose. So all these individual variations do happen because of the various factors, and in that sort of scenario, definitely the CGMs are definitely going to be helpful, and that's what Sonu has been discussing today. And in the special setting of the CKD, because it's also a very important setting where more rather than a hyperglycemia, we look into avoid a hypoglycemia. So there is something, a concept called a MARD, or the MARD, for the various CGM systems. It is called as a mean absolute relative difference, or how much percentage the sensor is differing, or it is varying from the true glucose measured from the capillary or the venous glucose. And the MARD of the latest Libre is very good actually. It is around less than 9%. When the MARD is lower, then the CGM sensor is better. And the Dexcom has a best MARD of around 8 to 8.2%, but Dexcom is rightly not available in India. The company has not started marketing in India, so it is not available. So that is why Libre is the one that we have. And the hypoglycemia MARD of Libre 3 is quite good compared to the first Libre. First Libre, the hypoglycemia MARD, that means the ability to detect the hypoglycemia correctly. By the first generation Libre was only around, the MARD was 15 to 20%. But now the third generation Libre, it is 11 to 13%. That means nearly 7% reduction in the hypoglycemia MARD with the Libre 3 it is, but Libre 3 is not available in India, but soon it will be coming up. And just words on the data also, like the Libre 2, yes, we have to scan in between, so that then only the it is like a flash CGM monitoring, then only the data will be updated in the app. But the Libre 3 is a continuous one. That is why 14 days, even if you do not scan, all the data will be transferred into the application. So that is a Libre 3, which might be available very soon in India, but right now we are using Libre 2. Over to Dr. Adon.
Thank you. And can just show the next poll, but I don't think this next poll needs to be discussed because it's already discussed. What target time in range would you aim in a CKD patient on insulin? So ideally it should be 70% for a normal individuals, but already discussed now. We can be very less stringent, and even a less than 50% is good. Only thing we want is to prevent hypoglycemia. Time below range is the most important thing for advanced CKD, and for other early CKDs, 50 to 70 or 70 what we can keep. So we can skip this poll and move to the next discussion. So thank you.
Now, the practical utility of CGM, as we all have discussed, is to avoid the hypoglycemias. How you can avoid the hypoglycemias is when you use the CGM data to adjust the insulins. So there are basically nocturnal hypos, which is predominantly caused by the basal insulin. So you have to reduce the basal insulin by around 20 to 30%. If there are postprandial drips, they reduce the bolus doses by 20 to 40%. And intradiabetic hypos reduce the pre-HD bolus by 30 to 50% and basal by 10 to 20%. In frail and elderly, go for very conservative reductions. And adjusting insulin based on CGM and CKD, basal insulin can be reduced by 20 to 30% in nocturnal dose because of reduced insulin clearance. And also see if the TIR is very high. If the TIR is more than 80%, at that time also basal can be reduced. Prandial insulin, if there is post-meal dips less than 70 milligram per deciliter because of delayed gastric emptying, then 10 to 20% reduction prandial insulin can be done. And correction dose, there should be by 25% lower dose for every 20 ml per minute drop in eGFR 60. Now, considering the insulin, this thing, we have a poll to launch. What is the biggest advantage of CGM in CKD?
So, what's the biggest advantage? It's already discussed partly. So you can just submit your opinion. So can poll results, please? So it's for detecting hypoglycemia. So it's very correct because we don't want hypoglycemia to be happening. And previously, Sonu was discussing how to adjust or titrate insulin and other medications based on the CGM. So in this context, I will share some one tip what we practice in our center. I commonly use CGM. So we have a nurse educator who applies a CGM, and many of our elderly patients and CKD patients are not well educated to retrieve the data every day and adjust the insulins or everything by themselves. So we'll apply the CGM, they go home, and 7 days we'll have the data. They come back after 7 days, and the 7 days data will be retrieved, and we read the data. And based on the 7 days data, we find out where all the hypoglycemias are happening, where all various spikes are happening, and we adjust the insulin dose or if it is OHA accordingly. And then we'll again send the patient home. The CGM can be in place for 14 days. The first 7 days, we understand the trend, do the corrections, send the patient home, and call after 7 more days. In the 14th days, we again retrieve the data, and we will see whether the corrective actions which we implemented could correct the blood sugar values in the next 7 days CGM. So that is one way which we do. So if it is an educated patients who know how, if we can teach them how to titrate the insulin dose by themselves, they can titrate it based on every day. They can just scan it to the phone, and they can do the self titration. And next discussion, please. Over to you, Sonu.
Now I would discuss 2 cases. First one is a CKD stage 4 on basal bolus regimen. 58-year-old male, type 2 diabetes mellitus, high HbA1c. His initial CGM shows significant nocturnal hypoglycemia and high post-lunch exertions. So the interventions, the patient was shifted to glargine, reduced bolus dose by 50% and added an evening snack. There was improvement in the time in range from 52 to 74%, and hypoglycemia was much less. Now the second case is of a hemodialysis patient, thrice weekly HD, wide glucose variability. CGM initially shows intradialytic hypoglycemia and rebound hyperglycemia post-HD. Dialysate glucose 100 mg per deciliter was added and reduced pre-HD insulin by 25% and added post-HD snack. TIR again improved from 40 to 70%. What we understand by these cases is that the hypoglycemia events were unrecognized before CGM, and after CGM we were able to quantify that, and that will help us to prevent severe loss. And the insulin dose was empirical, and after CGM it can be data driven, and there will be safer titration. Dialysis glycemia was unmonitored. Now the dialysis glycemia is profiled, and nutritional optimization can be done based on this. Now, CGM can also utilize in non-diabetic CKD to detect stress hyperglycemia, especially in acute kidney injury or patients on high-dose steroid therapy. And early recognition of this glucose variations can allow us to give proper dietary modification and monitoring. And reports suggest that 15% of CKD stage 4 to 5 patients have unrecognized dysglycemia. Now, there is correlation between the variability and faster EGFR loss. The pathophysiology is thought to be because of oxidative stress and endothelial dysfunction. And in the graphical representation, you can see that when there is significant glucose variability, there is high chance of EGFR decline. Now, CGM has also correlation with the cardiovascular risk. Glycemic variability is linked to major adverse cardiovascular events, arrhythmias, and QT prolongation. There is glycemic turbulence concept because there is increased variability which can lead on to increased microvascular and myocardial injury. CGM enables the risk stratification based on the coefficient of variation endpoints. Now, if you have to see the major evidences for CGM, the major CGM trials in the type 1 and type 2 diabetes mellitus have not included the CKD patients per se, but registry data and few observational studies from worldwide has shown that when we are using the CGM in CKD individuals, there will be decreased hypoglycemia episodes, decreased intra-HD variability, and glucose variability has correlated with the GFR loss. And the real-world evidence in CKD shows that CGM use in CKD patients has reduced hypoglycemia by 30 to 50%. Time in range has improved by 12 to 18%, And insulin dose has made, they were able to reduce insulin doses by 15 to 20% with improved and high chance of microvascular complications. In this context, I would like to ask Arun for discussing their data on CGM in dialysis patients.
So we just completed an RCT on CGM for dialysis patients. The dialysis patients were divided into two groups. One group will have a CGM, and other group is a control. And for the CGM, we just we monitored the blood sugars, looked for the hypoglycemias, and we did the corrective action based on the CGM. And the cognition using the MOCA score at baseline and 6 months and 1 year was being checked. And what we found that if we can pick up hypoglycemia is very common. The CKD patients, most all the diabetic nephropathy CKD patients are not on insulin once they are on dialysis because the blood sugars are controlled because it's end stage. They don't require insulin. But all these patients do go into severe hypoglycemia during dialysis. And each time they go for the hypoglycemia, usually their blood pressure also falls. So the blood sugar and the blood pressure dip is almost parallel. So if we can correct the hypoglycemia during the dialysis, we can prevent many hypotension episodes. So that is one thing which we what we could find out. And another thing is that we followed the patients, and if we do the corrective action, the cognitive decline is very less. Otherwise, the cognitive decline is very high. So we have to keep in mind that unrecognized or undiagnosed hypoglycemia in the dialysis patients is one of the important risk factor for the cognitive decline over the time. The patient is very active, starts the dialysis after 6 months or 1 year. They are not very active. They talk all sort of irrelevant things. They go into a dementia-like sort of thing. So this hypoglycemia is one of the correctable or preventable thing to prevent this complication. So that is, and we are due to publish this RCT very soon. So thank you, Sonu, for asking about it.
Now, what are the major barriers in this thing? In India, the most important barrier for CGM use is cost. There is around 4,600 per sensor, but we can actually bulk purchase for the hospital and we can give it from the hospital itself. Data access, patients may not be able to access the data by themselves by using their smartphones, but this can be circumvented by having a dedicated diabetes nurse or a dietitian, which may be able to access the data. And we are all aware that it is underused in nephrology, but the more usage of CGM will help us to fine-tune the blood sugars of the patients better. And there are some side effects because of this CGM. There can be skin irritation. There can be skin irritation in while using this machine. So it can be prevented by using a protective barrier film. And another issue is that there can be slight infections on the site of usage of CGM. This can be prevented by inspecting the site daily. Now, my key take-home messages will be HbA1c is unreliable in chronic kidney disease due to anemia and erythropoietin supplementation and transfusions. CGM is able to detect real-time hypo or hyperglycemia and variability. Data-driven insulin and nutrition adjustments improve safety. Evidences and real-world data support CGM use in CKD and dialysis. Integration is feasible, affordable, and improve the patient-centric care.
So, thank you, Dr. Sonu, for covering a big topic, a new topic, or a new topic for nephrology community in a very crisp and very easy way. And Dr. Sonu was just discussing about some barriers of using CGM, the cost and other things. In this context, I will just ask Dr. Jyotipriya here. So Dr. Jyotipriya is tried to apply CGM recently for her uncle. And for that, she called me and we had a discussion. And she had to go through a lot of pain and struggle to apply the CGM. So it would be great if she can share the real world difficulty in applying a CGM for a patient. Dr. Jyotipriya is here.
So as E.T. Arun told, my uncle was having several hypoglycemic episodes. So as per I discussed with Arun, and as per his suggestion, I recommended Abbott Freestyle Libre 2. So I advised him to buy from Amazon. Now, the buying itself was the first hindrance I faced, because there were different multiple versions and sensor types. So it was confusing. So what I found is that procuring the right device itself is the first bottleneck. Second thing, I have to teach him how to insert, how to use the sensors, and how to interpret the data, and how to interpret the trends and alarms. So luckily, my cousin was well versed in it, so she helped my uncle. But otherwise, in a normal scenario where majority of our patients are not having that technological literacy, so this will be an issue, like teaching them how to interpret and act accordingly. Because sometimes they may overact, adjust the doses by themselves. And another thing is seeing the values, patients may get panicked at times. My uncle used to call me every now and then, every day, some 2-3 times, the value is high now, what to do, value is low now, what to do. So imagine in a busy OP where you have 5 patients in CGM, and every now and then patients calling with these type of variations, it will be very difficult. So another issue is interpreting the graph itself. There are, like, if you look at the data, there is thousands of recordings every day, so many graphs, so many charts. So in a busy OP, if you're sitting and analyzing each data for every patient, it will be very difficult in our practice unless we have a support system, a diabetic educator or someone who helps us. So we need these areas, we need logistical parameters we have to overcome, we need a support system, and of course the cost thing is also, as rightly pointed out, that also we need to overcome. So this how to use it in our time restricted settings, in the busy practice, that actually we need to find a feasible option for this to make it more usable.
So anyone can just give a solution, a simple solution for this concern raised?
I think the solution to this will lie in the future, because as you know, even this simple blood glucose monitor that we are using nowadays, what is behind me here, that initially was not easy for people to use. And you had different techniques. And if you buy a new one, the different company, then the technique is completely different. So you get used to, but people get used to it. Now everybody's using that. So that has become commonplace. Similarly, I think with time, this will also become commonplace. But for that, like Jyotipriya said, one or two things: availability and cost. These two things are important. Now, some Indian companies have also come out with this. I have recently bought one called Sugar.fit. I've just ordered it. And they say that it's Bluetooth mediated. So it is continuous recording. So not like this Freestyle Libre where you have to do NFC. You have to go on recording with your mobile phone. So that way it will help. So I think with more companies coming in, more devices, then the cost will come down. Only thing is whether these devices are actually the real stuff or not, whether their monitoring is correct or not. So one of the other things that we have to check our blood glucose ourselves along with these devices. I did that first time I used this, and I found a lot of difference. That is, when I was using the Freestyle Libre, then my blood sugar would come out as 150. But when I see on the glucose stick, then it comes out 180, 190. And the other way around also. So there was both ways there was deviation. So I use only trends as a motto. The actual value I did not consider was significant. So these things are still there. Even a device such as Freestyle Libre, which is the standard of care right now, is still not as good as the glucose monitor. So therefore, we still have a way to go in CGM. I don't think it is for prime time right now, but I think in the course of less than 1 year, it will become important.
When in 1999, when the CGM first came, it was a very large one, and it had to add a cable and other things to for the data accession and other. So now it has came a long way, and it has become a small sensor with a very small protective covering. And the thing is that the newer CGM, there is no need to scan every 8 hours. Even in the Freestyle Libre 3, they can record up to 14 days, and all the other ones can record. The major issues that we consider as it measures the interstitial glucose. So there is chances that there is a lag time of 5 to 15 minutes. And there are some situations we have to consider when the patient is in dehydration, when he is in shock, or when he is having a sepsis or other such situations. The sugar monitoring may not be reliable while using a CGM. And there are some other things. The drugs such as paracetamol and high dose vitamin C can interfere with the glucose oxidase systems which are used in this CGM sensors. And at that time also there may be variations. And the market insight says that if the paracetamol daily dose is more than 4 grams, that is the situation only which with the recordings will be affected. So such issues are there, but what is being that is that this is the metric that gives you a very clear understanding of the patient's sugar pattern. And in the time of dialysis and these things, if you are using the glucose strips hourly or every 30 minutes, a standard glucose strip will cost somewhere around 25 to 40 rupees. So if you are recording sugars at the same frequency as that of a CGM, it is cost effective if we consider in that way. So for patients who can afford, this is something which can be used.
Great.
And they are telling that if there is a significant difference in the values, that you have to be correlated with the SMBG and SMA patient have to have a glucometer also along with him while using this.
Gogul, are you here? Gogul had an interesting case recently. Gogul had a patient with Gogul, are you here?
Yes, sir. Yes.
Dr. Gogul? Yes.
Yeah.
Dr. Gogul had a patient whose HbA1c is always very high, but whenever they do come with the blood sugars, it is always low. So fasting sugars are low. Many of the times postprandial sugars are low, but high HbA1c, and ultimately he decided to do an CGM. And can you just share that case very quickly before we go to the quiz session?
Hi. Yeah. I basically had a relatively young guy around 40 years of age. And he was on metformin for quite a long time. He was on metformin for the past 2 years. But his HbA1c could never be controlled. It was always around 6.8 to 7. But whenever he comes with the fasting values, his fasting values will be always around 90. Postprandial values, 1.5 to 2 hours, the values are always less than 140. But his HbA1c was never controlled. He always had this neuropathic symptoms. He always had this tingling of extremities and all. So I just decided to go with this CGM. And interestingly, I found out that in spite of good diet compliance and all, he always used to have a postprandial spike of his glucose. Immediately after half an hour to 1 hour, he has a good spike in which the sugar spikes to around 200. And after the 1.5 hours, the sugar values come down to normal. So that is why he was not able to pick up these values. And metformin, as we know, it does not control the postprandial sugars. So with this CGM, I was able to, I changed to, initially changed to gliptin because he wanted initially a drug which can be given once a day. So I changed to linagliptin initially. And I found out that these spikes came down significantly after starting linagliptin. But even with that, the spikes were high. It was spiking up to 150, 160 and all. So we just wanted to bring his diabetes into remission. So I just gave him the option of changing him to voglibose. And with voglibose, he's fairly doing well. And now the spikes are controlled. His neuropathic symptoms are well controlled. It's almost around 3 months, and his HbA1c come down to around less than 6 now. So this is one thing, one use of CGM which I find it very useful for a patient of mine recently.
Thank you, Gogul. It's time for a quiz. Time for our great quiz master, Kishore sir is here.
Our Prem sir's opinion.
Dr. Prem, can you just give a concluding remark about
Hi.
two or three important takeaways?
Yes, a great discussion. So one thing just I would like to add was that when there is a rapid glycemic fluctuation, so in that sort of scenarios, like a patient on hemodialysis or undergoing dialysis at that time, so the interstitial glucose, there will be rapid changes. So it will be very difficult for the CGM to accurately sense that. So in that sort of situation, definitely a confirmation. If the sensor is showing a low glucose, then confirmation with the glucometer value will be warranted. And as we were telling, yes, it's a very new area, and we are getting more and more used to it with the usage of sensors in the different scenario. But in the critical care setting and IP setting and all, so we need more data because these are the scenarios, especially in a patient with CKD and all, where the scenario where there can be a lot of glycemic fluctuations can happen, and that can be even false low. So it is not that false low with the sensor can happen. Yes, it can happen. So that also has to be, we have to keep it in mind. So whenever a confirmation is needed, so always better we can measure it with the glucometer also. And as Dr. Gokul was putting up on the case scenario, so yes, definitely many of the glycemic spikes, because there are a few subset of CKD patients, even under my follow-up also, where their insulin resistance is so high that even none of the newer insulins work. So I have to go back to the old R and N insulin, like the NPH and the R insulin. And in that sort of situations, patients, that only the thing that works. None of the newer ones like the Toji or Tresiba or nothing works, and we have to go back to the old NPH insulin. So that sort of scenario also is the one thing where we can use the CGM sensors to locate the hypoglycemias, because when we use older insulins, the risk for hypoglycemia is also definitely on the higher side. So in that is also one scenario where I would like to add that CGM will definitely be beneficial in a patient with CKD. Otherwise, yes, I think almost everything, all the aspect has been discussed. Cost is the one. Yes, even be it an endocrinologist or be it a nephrologist or be it any specialty, the cost is the one that factor matters in the Indian scenario. 5,000 rupees or 5,400 for 2 weeks. Yes, most of the patients will say no only. Is in special case, so right as of now, choosing the right patient to monitor. Yes, I mean, well affordable patients, no problem at all. But otherwise, where you would like to use it, on what is your target in that person, whether it is a glycemic spike or whether it is a hypoglycemia that is happening. So all these things can definitely be useful. And the Medtronic sensor, as you know, it is for 7 days. It costs around 3,500 rupees. So 2 weeks, it will cost nearly double, means 7,000 much more costlier only. So as of now, we are contented with the Libre 2 and more and more data on the reduction of the complications. Yes, we have good data on the reduction of the microvascular complications, some macrovascular complication reduction, but more and more data will evolve. And there is one more sensor similar to the Abbott Libre, that is like something like the flash sensor from a Chinese company called Sinocare, but they have placed it even much more higher. It costs nearly 6,000 rupees. So we are not using it. So we are mostly now contented with the Libre 2. So that is it from my side, Arun. Over to you.
Thank you.
Sonu.
Thank you very much, Dr. Prem, for the insights.
Thank you.
And this is the last poll. And has this session influenced you to consider using CGM more often in your nephrology practice? This is a poll Sonu wants, whether his talk is effective or not. Let's see. So can you share the results? Results, please. Yeah. So still not yet. It's not if 5% is still to get motivated for CGM, but majority will be using CGM. It's a great job, Dr. Sonu.